Welcome to today's MESUD Learning Community Echo, Substance Use Disorders Through a Pharmacy Lens. Today we'll be hearing from Whitney Jandreau on stigma. My name is Bethany with CCSME and I will be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been approved by the Maine Board of Pharmacy for 1 hour of continuing education credit. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for 1 AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. Whitney, would you like to introduce yourself and then you can share your screen and get started with your didactic?
Hi everyone, my name is Whitney Jandreau. I'm a clinical pharmacist for Sebasticook Valley Hospital in primary care. So I have two practice settings, inpatient and outpatient. In my outpatient world, I do opioid stewardship and help with pain management consults and opioid tapers, transitioning to buprenorphine and things like that. I do have a strong passion for substance use disorders, and I'm really excited to be here. We're talking about substance use disorder through a pharmacy lens, and I'm going to talk about stigma today. I think there's probably a bit about continuing education credits in the introduction, but here's the written form of that. Neither myself nor the program have financial conflicts of interest to disclose. And I briefly want to go over a few learning objectives for this portion. So I want to identify types of stigma that are related to substance use disorder. I want to talk about non-stigmatizing words and phrases that we can use to build trust with patients and have a more caring healthcare team environment. And then also to outline steps that pharmacy staff can do to reduce stigma within the pharmacy, within patient interactions, and also at the health system level. So I think everyone is well aware of stigma around substance use disorders. It's one of the most stigmatized conditions worldwide. And this is a quote from former U.S. Surgeon General Jerome Adams. The biggest killer out there is stigma. Stigma keeps people in the shadows. Stigma keeps people from coming forward and asking for help. Stigma keeps families from admitting that there is a problem. I think that's really powerful. All of us, regardless of our practice settings, have seen examples of stigma, and we'll talk more about that. But we have a public perception problem with substance use disorders. And this is a statistic from a survey that was done in 2021 of 8,000 US residents. 75% of those residents believed that substance use disorder was not a chronic medical illness. And so, that of course begs the question, then is this because of a moral failure? Like, is this because of choice? What are the perceptions of that 75%, the majority of our public? And this is really unfortunate. And this really underscores the magnitude of the problem, because all of us are part of the public. And as much as we would like to say that stigma doesn't extend into healthcare settings, it certainly does. And again, ultimately prevents people from seeking out the care that they need. So I'm going to do a brief overview on different types of stigma. There's layers to this, like an onion. So as I mentioned, all of us recognize the stigma that exists around substance use disorders, but when we think about it a little deeper, we recognize that there are multiple different types. As I mentioned, people who are experiencing substance use disorder are treated differently even in healthcare settings because of the stigma that exists. Healthcare providers generally have lower expectations that someone with a substance use disorder will recover. And there tends to be also just emotional components that come into play as well, which may stem from stigma. So, within that provider and patient relationship, resentment, frustration, and so on. And we know stigma worsens treatment outcomes. So even if someone has overcome the stigma barrier to look for care, they're less likely to have positive outcomes because of the stigma that remains in that care setting. And we have stigma against self. So people who have a substance use disorder have been socialized to believe there's something wrong with them. That stereotype gets internalized, unfortunately. There's public stigma, as I mentioned, and the majority of people having a negative perception about people with a substance use disorder. And there's also stigma against medication treatment. And that stigma might come from the healthcare side, where, maybe a prescriber is unwilling to prescribe medication for a substance use disorder, but also comes from the patient side. That internalized messaging that I'm just replacing my the substance of choice with another medication, and that's not truly a pathway to recovery. And there's also structural stigma. So, we know that there are marginalized groups and there's structural barriers that compound and prevent people from receiving care. And, all of these factors can be at play in any particular interaction or case that we might talk about, and we'll come back to that. I want to spend another minute on MOUD stigma, or intervention stigma, as the authors of this study called it. And I just want to point out, there's varying levels of stigma depending on the medication for opioid use disorder. And they actually found that in this study, the stigma against methadone and buprenorphine was higher because of the pharmacological properties, with those, being opioid agonist medications versus the stigma that might exist around naltrexone. And this is really impactful because if your stigma is driving your medication selection based on a variety of these factors here, the drug properties, thinking about maybe regulatory barriers, suspected profit motives, I thought was an interesting stigma against, methadone and buprenorphine, that were kind of trapping people, in this medication for the rest of their life, and that might be some sort of financially motivated reason why we would prescribe these medications. What you'll see is we might actually choose the medication for opioid use disorder that has the least amount of evidence for effectiveness, which would be naltrexone. So, this really impacts our patients and care decisions. And I thought this was a really unfortunate but interesting example of how stigma against medication for opioid use disorder might, again, even be there after we've gotten over some of the stigma hurdles. So we're ready to, okay, sure, we've gotten over the hurdle of, medication stigma, and we're going to prescribe, but now we've got stigma within stigma, and we're going to choose a medication that might not be the best option just because it's less stigmatized than the others. And so I'm going to pivot a little bit here and talk about stigma in our language. It's incredibly important for all of us to unlearn stigmatizing terms and work on our own patterns of language, not only with patients so that they understand that we're speaking about their substance use disorder as a medical condition, but also in our healthcare teams. There are several generations of healthcare providers in our teams, and some of us learned stigmatizing terms as part of our training, and we have to undo that. So this table gives you stigmatizing terms all the way on the left-hand column, and then preferred terms and a rationale. And I have a box around relapse because I think that relapse is one of those more nuanced stigmatized terms people don't recognize. And I have an interesting article that's linked on this slide if you want to go in and read it. But it's time to quit using words like relapse. Relapse is stigmatizing. Relapse does not align with the chronic disease model that substance use disorder should be aligned with. And so the preferred alternative to relapse would be recurrence of symptoms requiring medical attention. That is the the chronic disease language that we should be using rather than something like relapse. And you can see other stigmatizing terms. I think some of them are a bit more straightforward there and understanding why they might be stigmatizing, but all of us can reduce stigma just by changing the way that we speak. This is something we'll come back to with the case. But this is just a thought exercise and looking at asthma, hypertension, and diabetes as chronic diseases, and then thinking about how we describe the recurrence of symptoms for those diseases, and then how do we describe it for substance use disorders. There's a high rate of recurrence of symptoms between substance use disorder and other chronic illnesses. You can see that graph on the right. Again, we'll come back to this, but recurrence without MOUD, if we're just looking at OUD, is very high without medication treatment. And so this is a common issue that comes up frequently that we all should be aligned with on language. And so, words is one kind of intervention against stigma. I also want to mention that there's a fair amount of stigma against harm reduction. And from a pharmacy perspective, you can see this across different care settings. And harm reduction essentially, it meets the patient where they are. We can accept that there will be some level of substance use, but we're providing safety measures to reduce the amount of harm that might be associated with that. So, rather than just concern around the consumption or quantity of consumption of substances, we're actually worried about healthcare outcomes, social impact, and even economic impact as well. And so on this slide here, there are 3 images. We have different types of harm reduction. And I would be shocked if everyone in the audience could not describe to me how, they've seen stigma against naloxone, either from a patient perspective, a family perspective, or, in a healthcare team. I would be shocked if you hadn't heard any kind of stigma against supervised injection sites, which are actually proven, evidence-based intervention to save lives and save money. And I would be really shocked if the people on the call hadn't heard of stigma around needle exchanges or providing safe, clean needles in community pharmacies. There is a fair amount of stigma around harm reduction. And there's a fair amount of work that we need to do to describe the evidence behind these interventions and normalize harm reduction. In my case, we'll talk a little bit more about stigma against harm reduction once we get to that point too. So I have to credit some of these slides are from a CE that Stephanie Nichols and I did together at a pharmacy conference. But this is, I thought, a nice summary of rules to avoid stigmatization on an individual basis. And if we can all, internalize, use person first language, don't speak about people in a way that is stigmatizing, first and foremost. Also important to differentiate substance use and substance use disorders and to not interchange those. Those are distinct. We should all be using technical terms. This is a chronic illness. We should be using medically aligned terminology as we would for other chronic illnesses. And I think just describing, providing education that these are chronic illnesses, to your patients, they may not believe that. They've been battling a stigma their entire duration of their illness. So there's probably a fair amount of self-stigma that you have to break through with your patients just to even get them to understand, they're dealing with a chronic illness. And the more that you use that clear and simple language with your patients, their family members and friends and your teams, the more everyone else will begin to adopt that language as well. And then, just thinking about the way we communicate, thinking about the stigma that we might be inserting into statements that we're making, assessments that we're making, and being really careful. And I know it can be kind of tricky to learn, how do I talk about this without being stigmatizing, and you're going to make mistakes. One thing that I found at Eastern Maine Medical Center, we wanted to roll out some education for patients about naloxone. as well as buprenorphine. And this was a place I felt we could really lean into scripting and written education to reduce stigma that might enter the conversation if we did not provide this scripting to our staff members. So, when providing education to patients about these medications, can you support your staff members to remove the stigmatizing language and align the messaging so that we're all on the same page? We're providing consistent messaging and everyone is more comfortable because they can see an example of how to speak about this without stigma. The same thing would go for, policies and other, written documents that you have in your healthcare system. And that's one of the tips for breaking the cycle of stigma at the systems level is performing a language audit. If your policies contain stigmatizing terms, remove them. Every opportunity that we have to change the language will have a ripple effect in our healthcare system. Consider looking for other sets of eyes to review material before distributing it. Getting ideally a person who has lived experience with a substance use disorder to review and be more keen to find stigmatizing terminology are really great tips for how to move our written material towards a less stigmatizing reality. And then, of course, providing training for staff, because all of our staff are coming from a place where we've been socialized to have a stigma against substance use disorders. How do we reverse that? I think it's really interesting that, and oops, there's some animations here we're going to have to walk through. I think it's really interesting that we don't have a lot of education around substance use disorders in healthcare training. And, we're not necessarily given the opportunity to provide this early on. And I do think that time is changing for sure. But a lot of us have kind of been trained under this stigmatizing kind of environment. So we need to do a lot of work to reverse that and to get everyone on the same page. So this is another credit to Stephanie. I just love this quote. Language matters, words have power, and of course, people are first. So words are important. If you care for something, you call it a flower. If you want to kill it, you call it a weed. And so again, credit to Stephanie for this slide and for bringing that quote forward. But it's so important. And this is a way I think we all can understand and relate to. Language matters. So I'm going to kind of run through a couple of other ideas here before we pause. I just want to point out that there are evidence-based ways that we can overcome stigma to prevent opioid overdose. And I've highlighted all of the MOUD related interventions here. And this is just a thought exercise, not going to spend much time on it, but I just want you to think about, if these are the evidence-based strategies to prevent opioid overdose, where does the stigma exist? So we know there's stigma against harm reduction, there's stigma against naloxone, we know there's stigma against MOUD. Where can pharmacy reduce stigma in all of these strategies so that these strategies could get, off the ground and in your healthcare setting, in your system? So a thought exercise and something that I hope that you come back to and think about these different interventions in your setting. Whether you're in a community pharmacy or you're in a healthcare system, what can pharmacy do to reduce the stigma and get over the barrier that might exist to implement these best practices? So I'll also just want to make everyone aware of the 1,000 Lives campaign, pharmacist, and I added pharmacy commitments because pharmacists don't do anything without the support of technicians, interns, and other support staff. But the 1,000 Lives campaign is a model from the Maine Medical Association, and they have put forward suggestions for healthcare systems across the state to save 1,000 lives in the next 5 years. And so the pharmacist commitments here, which again extend to all of the pharmacy, is first and foremost treating patients with substance use disorder with dignity and respect, avoiding stigmatizing language, and offering supportive care. So first and foremost, dignity and respect. If you can build a relationship with your patient, they're much more likely to stay engaged in treatment. You're much more likely to save their life. And so I don't think it's coincidence that that comes first. And then, there's other information here I'll let you read on your own, but I wanted to call out stigma and reducing stigma as a priority here. Another priority for the Maine Opioid Response Clinical Advisory Committee. So if you're not aware, this is specific to hospitals, but again, we're looking at a level of recommendations to provide basic care for people with opioid use disorder. And training around stigma for your staff is first. So first and foremost, and everything else comes secondary. So I think we can, learn from these experts in this field in the prioritization and the effect of stigma that it is a course that runs through all levels of care. It even prevents people from reaching the door, but then continues to affect patients who have even overcome that hurdle and find themselves seeking care wherever they are, whether they're filling a prescription at your community pharmacy, they're coming to see you in a clinic, they're hospitalized, they're in the emergency department. There's a lot that pharmacy can do in all of those care settings to improve patient outcomes by reducing stigma.